Well, that last one was successful, so I'm moving on to the next, parental fluid and electrolyte replacement. This is not a specific chapter in your text. While I'm saying that, I also want to tell you there's a PowerPoint that you'll see for Unit 1 that I do not talk. It's just a PowerPoint for dosage calculation. No, you're covering it in lab. You're getting it from many directions. I just wanted to give you additional information because it is here. Dosage calculation, there is a chapter in your text, chapter 5. It goes all through things you might want to go through here. It will help you hopefully in lab because you have to pass those med tests. And there will be calculations on all of your exams, especially in pharmacology. So that's a good chapter. The PowerPoints to help you too. And the parental fluid and electrolyte replacement that I'm going to cover here. I am doing this because there isn't really a place. It's kind of, you get this throughout the program. And what I've seen that the students never quite get it, so I decided that this was the appropriate place for me to put it in. So major fluid compartments of the body, intracellular and extracellular. You can see 40% of the body weight is on the intracellular fluid. Extracellular is outside the cell, so it includes what's in your blood vessel and what's just plain outside of the cell itself. So here inside this intravascular and the interstitial, that is called extracellular. Okay, so electrolytes, the major electrolytes, intracellular, ICF, inside the cells are phosphate and magnesium. I should say potassium, sorry. So your potassium and magnesium in your cell are the major, and your sodium chloride, I always think of sodium chloride always put together in my head. So sodium chloride outside the cell, magnesium, potassium inside the cell are the major, but you can see they exist on both. Purposes of infusion therapy: to provide fluids when they cannot take it by mouth or they need additional. Appendix, I see I have written here, Appendix A, let me look here. Okay, so in your text, parental agents, Appendix A talks about contraindications, cautions, parentals. Table A gives you the parentals, the different types of fluids. Don't worry about calorie count or osmolarity, just their usual indications when it's used. If I have not, I think I did. If I've not, I have an IV fluid cheat sheet that I'm going to load up for you. Your table goes through all the way up to 1040, 1041. Giving you all kinds of information about all the different fluids. But I'm trying to break it down more for you. Maintain normal electrolyte balances, provide glucose as an energy source, provide access for administration meds, administrate blood products, emergency access, maintain urine output. So multiple reasons that they are used. As a nurse, you should be familiar with the different things, what it's used for, when it's used, which product's appropriate. Okay, so tonicity versus osmolality. You will hear fluids referred to in both aspects. Isotonic solutions have the same osmolality as the body fluid. It's equal. Isotonic keeps things equal. Hypotonic solutions have a lower osmolality than body fluids. Hypertonic solutions have a higher osmolality than the body fluids. It has to do with where you want the fluid to move. Do you need it to move into the cells? Do you need it to move out of the cells? So that's how you choose a hypotonic, hypertonic, or isotonic if you don't want the fluid moving. Okay, so IV fluids used. This was a really good picture on crystalloids versus colloids, and of course blood products are their own thing over here. But colloids, easy. This is like protein things. Sometimes albumin is actually dextrin. Some of these sometimes are listed more on the blood product side, and I'll get into that a little more. So your crystalloids, if you don't know them, you should be familiar with dextrose. 5% dextrose in water is what D5W is. 10% dextrose in water. 50% dextrose in water. These people often will refer to as D5, D10, D50. Saline, isotonic, 0.9% saline. That is because that is the percentage of saline that is, or sodium that is in our bloodstream. So it is isotonic. It's not going to move things in or out. Hypotonic. And I said on the previous slide that hypotonic, lower osmolality than the body fluids. So a hypotonic solution is, if isotonic is 9%, hypotonic is lesser, so it's 0.45%. You'll see it ordered or listed as 0.45% NS, normal saline, or it'll be written as half, or set verbalized as half normal saline. They'll write it as but that's what people call it, a 0.25% normal saline. I don't know that I've ever actually seen that administered, but half normal saline, normal saline. These are terms to get familiar with. So hypotonic, 0.45% normal saline is called half saline. Isotonic, 0.9% normal saline, people will refer to as normal saline. And then the hypertonic is if it had extreme higher than 0.9% sodium in it. Combinations, you will see this people will call D5 half, which you could see here. It's 5% dextrose and in water and a 0.45% saline. D5NS or D5 normal saline, again, is the same. D10NS, I think you can figure out from there. Balanced, Ringer's lactate. When it has the potassium, bicarb, magnesium, calcium, it has the things your body needs to keep it balanced. And PRC, PBRC is packed red blood cells. PRBC. Could not get that out. I don't remember. I'm looking ahead to see whether I covered it more. Yes, I think I talk a little bit more on the blood products. Okay. This is a good chart for helping you. Here's your hypertonic, 3%, 5% saline. Hopefully after seeing the other slides, you can go back to these. This, you should be able to work your way through these. So if we had to miss a day in the class, this isn't a bad one to miss. Isotonic solutions used to correct or expand extracellular fluid, giving them extra volume. Hypotonic solutions cause the fluids to shift out of the vascular or extracellular fluid and into the cells, used to provide water and cellular hydration. And hypertonic solutions, like over here, causes the fluid to shift out of the cell, the intracellular fluid, into the vascular space. It's a rapid shift. It's given to treat specific problems. Here's another I found that I thought would be very helpful for you. Again, I mentioned you have Appendix A that goes into parental fluids. Some of you might find this a little easier in helping you remember, where it gives you cautions: hypotonic, hypertonic. Don't give D5W to infants or head injury patients, may cause cerebral edema. I thought this was just a really good slide to help you grasp some of these. Blood products. So these are all blood products. PRBCs or RBCs, you will packed red blood cells. Occasionally you'll actually give whole blood 99.9% of the time, you're going to give PRBC, which is packed red blood cells. They condense it down and they get all the red blood cells, but they don't get the volume. Fresh frozen plasma, you'll see it or you'll hear it or see it written as FFP. Fresh frozen plasma to correct deficiency in coagulation factors or to treat shock due to plasma loss from burns or massive bleeding. I've been in situations where you're hanging both of these constantly on a bleeder, like a GI bleed or something. And coagulation factors, I've seen that hanging FFP when someone goes into a DIC, disseminated intravascular coagulation. Not sure if you've covered that yet. When you do, fresh frozen plasma should pop in your head. When whatever happens, their body uses up all their clotting factors. So you're giving them fresh frozen plasma, trying to give them back. Or you're also those situations where you're going to often give them platelets. It says concentrated platelets. You can see from the picture, it's very little in the bag. I know the first few times I hung platelets, I'm like, that's all you're giving me? When I got to the blood bank, all of these come from the blood bank. When you have a really low platelet count, you are transfusing platelets in. All of these are transfusions because they're all from blood donations. Cryoprecipitate is to treat fibrinogen deficiencies. I've hung that a few times. And you see here that it's in the freezer, and this one's in the freezer. When you start working, fresh frozen plasma and cryoprecipitate are the kind of things that you should learn in policy at your facility, that you call the blood bank ahead of time so they can get it out of the freezer, put it in the warmer, prepare for you to pick up. Hopefully you've covered things with blood transfusions in other classes on reactions, problems, making sure you're checking IDs. The patient's ID, you check it when you get to the blood bank. You check it with somebody before you hang it in the room. You check vital signs 15 minutes in and 30 minutes in because you're watching for a transfusion reaction. Don't get too comfortable. I worked trauma, OR, vascular surgery, open heart, so I gave blood so many times. And I had an open heart patient that had to keep getting blood products, and I don't know how many I hung in my shift, and went to the blood bank, verified numbers with them, came up to the bedside, was verifying numbers again with the nurse, and one of the numbers was off. It was the craziest thing in all 30-something years. I've only had it happen once. And somehow, when I read the numbers in the blood bank, she said it was okay. When I got upstairs, we noticed one number was off. That was a very close, scary call for me. So when you start to get comfortable, I'm glad things like that happen to wake you up. Here's a little more information because I don't know what you have and haven't gotten. I said, I'm just trying to make sure you get the tools you need because this is just areas I think that somehow didn't get, I don't know. I just want to make sure you have it. Transfusion reactions. There are 3 types of transfusion reactions. Regardless of the reaction, stop the blood. Maintain the line with normal saline. If you haven't hung blood or seen it hung, there's a Y tubing. And the reason it's in a Y tubing is you have saline on one side, the product on the other side. That way, whatever the blood product is, you can turn off the blood side and open the saline side. A lot of times what happens is I don't want to give them more blood than I have to. So I might just just get the saline going. So reactions, allergic, can be from mild facial flushing hives to severe, like an anaphylactic reaction is that increased anxiety, wheezing, dyspnea, and drop in blood pressure is anaphylaxis. Febrile reaction, fever, chills, anxiety, headache, tachycardia, tachypnea. I saw that in as much blood as I gave. I only saw that once, thank goodness, but it was pretty rough. Hemolytic, this is if you give the wrong product or it was not checked appropriately. If they have a hemolytic reaction, can be fatal. Fever, tachycardia, their blood starts clotting on its own. They get chest pain, apprehension, low back pain. They go into shock. It's bad. Okay, TPN is total parental nutrition. I didn't bother putting a picture up here of PPN, which is peripheral parental nutrition. The difference between the two is that peripheral parental nutrition, say that 3 times, is a tongue twister. Peripheral parental nutrition has a lot less of the glucose. You cannot take that peripherally, so they have much higher concentration. Total parental nutrition, all total parental nutrition has to be given through a central site. It is high in sugar, glucose, so that's where your tubings are changed out daily because of the glucose, because of the potential bacterial growth, and why you're checking the site and changing the dressing on the central line site too, for that reason. I found this picture I thought was good because sometimes you will have somebody that has their TPN and they have orders where they're going to get lipids that you will infuse once a day. Other times they're getting the white lipids in every bag, and sometimes they're just having this bag alternate with that bag. The bags hang for quite a while. It's also another that you have to double check your orders all the way down and double check with someone else. At least what I'm used to, double checking with someone else before you hang any kind of TPN or PPN. The pharmacist and the dietitian in the hospital are ones that together do this. The pharmacist is often the one actually writing what it is and checking the labs to make decisions on the next one. And that is the end of this lecture.